This is DC EKG, exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan.
Welcome back to DC EKG, the most informative healthcare podcast out there. I'm really excited today to have Naomi Lopez with me back again. She's the founder of Nexus Policy Consulting and the recent co-host with me of the first Healthcare AI Policy Summit, which we hosted together last week, December 10th at NEDS. Naomi, thanks for coming.
Thank you so much for having me.
So let's walk a little bit. I thought it was a great conference, and I'm going to give you all the credit in the world because I didn't want to do it. I was swamped. I was busy. I'm like, okay, I need another thing to do, like a hole in the head. But it was a great conference. You did a great job. It was your vision, and thank you for pulling it together.
It was my pleasure. And I think that, we started working together about 2.5 years ago on the Healthcare AI Working Group, which was an informal group of healthcare / other policy area experts in order to build a bench of healthcare AI experts in order to ward off some of the Biden administration's regulatory overreach on AI. And this was just a logical extension of it. So I think that our partnership over the past couple of years has been very, very productive.
Yeah, thanks. Well, it's been a pleasure because you certainly are an expert on state healthcare policy, but state policy general, legislative procedures, and the machinations in all 50 states in a way that I certainly am not. So it's a great partnership. It was a pleasure to work with you. So let's get into it. So we had this thing. It was a busy week in DC for AI policy, and I thought it was timed very well, and I'm glad we got it in 2025. So we started off the conference with the Deputy Secretary of Health and Human Services, an old friend of mine, Jim O'Neill, who came and was very generous with his time and talked a lot about the department's approach to AI and where they want to go. Now, Jim is a veteran from the Bush administration, where I first got to know him, where he worked at HHS. And then he had spent a number of years out in Silicon Valley and working with Peter Thiel. But he's got an entrepreneurial bent. He's got a tech bent and a libertarian bent. And he's very focused on trying to create an environment for new technologies to flourish, get adopted, get regulatory approval if necessary, get reimbursed if necessary, and improve the human condition in healthcare through new technologies and innovation. So that was a great way to start the day. I interviewed him, so I was probably more nervous about not forgetting anything that we wanted to ask him. And I'd be interested in your impression of the interview and your takeaways from what Jim had to say.
Yeah, I thought it was a fantastic session. And actually, all of the sessions were fantastic. But I really appreciated, so he brought this high level of institutional knowledge and regulatory know-how back into this position. And, we had a lot of innovators throughout the day. But I think what his huge value add to our day was that he's an innovator inside government. So he understood very clearly the need for regulatory clarity, the lighter touch regulations, and streamlining the approval process for AI and machine learning enabled devices and tools. And the other interesting thing that he brought was he is also helping to promote the adoption of AI within government, which you guys also talked about. So I think that there on multiple levels, his ability to not only make the ground more fertile for AI by providing the regulatory clarity and streamlining, but also to make government operate more efficiently. We've had, decades ago, we had, a lot of initiatives about making government better, but this is truly one way that government can be streamlined. You can remove a lot of the duplicative tasks, really focus people on higher value add within government. And so I think that, we only had one day, but we could have
Right.
spent multiple days with Jim alone in talking through some of these issues. And so it's a really exciting time. Access and TEMPO were both announced recently.
Why don't you talk a little bit about those initiatives?
Sure. So Access is an outcome adjusted payment model for Medicare for chronic disease management under four key areas: like high blood pressure, diabetes, musculoskeletal pain, and depression. And so these four chronic areas affect more than 2/3 of Medicare beneficiaries. So what they're doing is they're bringing in a new model of payment to demonstrate it over the next 10 years to really provide real world evidence, proof of concept. Meanwhile, TEMPO is an FDA initiative that is going to also be a new risk-based approach to regulating new tools in chronic disease management. So what they're going to do is they're going to allow 10 non-certified tools in each of these four disease areas to be piloted, and using that real world evidence to hopefully create another pathway for the more rapid adoption and more efficient adoption and post-market surveillance, et cetera, on these kinds of tools. There's not a really good fit right now in the FDA for approving these tools. And we can talk about that more in our discussion today, but it really does show this very action-oriented HHS. And I think that there's a lot to be excited about.
Yeah, I mean, the access model, just to hit on that. So that's coming out from the Center for Medicare and Medicaid Innovation, which is run by Abe Sutton, really good guy who we used to work together in the first Trump administration. But one thing that's interesting about it is, for so many of these chronic diseases, for Medicare beneficiaries, the new wave of AI-enabled technologies that we wouldn't consider traditional medical devices, like, well, I'm wearing a Garmin right now. You could see devices like this getting configured to monitor blood sugar content, monitor heart rate, monitor any number of things based upon different inputs that it's taken, and then flag these for your physician, for a nurse practitioner, somebody out there who can intervene and get you on the right track. So you're not cycling through this series of ever deteriorating conditions or crash and burn, where you're going fine and then you're slipping and you don't even realize it. But there are devices and wearable tech that could flag that for you. And then, of course, that's a ton of expense. The chronic conditions are a ton of expense in the federal government, but these episodes of catastrophe in the emergency room are a tremendous expense as well.
Well, and to provide additional context on what this could mean in the long run, when we think about the ability to remotely monitor patients, we now have ICUs where the patient is actually in their own home, surrounded by their loved ones and caregivers in their own bed, which has a huge impact on the cost of the episodic treatment for that patient, not having to be in the four walls of the hospital. But also, when we think about the Medicare population, we've got an aging demographic in our country, and we're going to have to reckon with that. The cost of long-term care will be borne by the states. Medicaid will pay for long-term care for some populations, for those that qualify. And when you're talking about $50,000 to $75,000 per year per patient for long-term care, which is usually not very good in this country, unfortunately.
Right.
The ability to remotely monitor patients and allow them to age in community can have substantial impacts on state budgets. Most people don't realize that states are required to balance their budgets every year. They don't have a printing press. Those are legal requirements on states. And those dollars squeeze out money for other high priority expenditures like education and transportation. So we really do have, what I'm really excited to see is that there can be significant impacts on state budgets, but also the quality of life for our aging population in this country.
Yeah, it's a really good point. Let's go back to Jim for a second. There were a couple things that I took away from that conversation I thought was interesting. One was his libertarian instincts came out on a number of these issues, where I think a lot of the media narrative is AI is running amok. The AI bros are running amok in the administration, the Trump administration, by jettisoning the Biden administration's completely prescriptive hostility towards AI and really focused on government control of this technology has somehow lacked skepticism of people using AI for nefarious purposes. I thought he was very clear that he doesn't see it that way. As a matter of fact, I was pressing him on a bugaboo of mine, which is the government doesn't release the data that it has for people to research and evaluate. And I said, look, it has tons of claims data and CMS that could be put out. And he said, yeah, it could be, but with AI, you could figure out who these people are, an individual patient, if it's not done properly. And kind of said, yeah, that is a focus to get more government data out there for public consumption. He was focused on using AI, for instance, for better predictive modeling on pandemic and epidemic response. But it was interesting that because he's an innovator, because he's been in private industry, he isn't either openly hostile or totally gullible. He knows what the opportunity is, but he's also like, wait a second, we have to be careful on a couple of these things. Otherwise we could end up regretting it down the road.
Yeah, I mean, I thought that was a really important point about de-identifying data. A lot of patients, rightfully so, are very concerned about their data being shared. Whenever you think about, for example, if you have a patient with a rare or ultra rare disease that lives in a certain zip code, it would not be that difficult in a year or two to figure out exactly who they are and, who their family members are. The other thing I thought was really fantastic that came out in the panel were when you asked him about Chai, when you asked him why he came out so strongly, making it clear that the federal government is open for business for small tech and that they don't need to pay an intermediary in order to talk to HHS. And I thought that was a really important point and really is, I think one of the big criticisms of big tech is this idea that they're going to have a monopoly over innovation in the space. And he is very clearly a protector of making sure that small innovators can, in fact, innovate. So I was very pleased by that.
Right. Yeah, no, that was great. I mean, CHAI, the Coalition for Health AI, to your point, he wanted to dispel this notion that there was going to be any organization that stood between innovators and the government, and that you would get an edge or needed to pay a fee, and that there would be a third-party private sector validator for any technology. And I thought it was important that he had written an op-ed, I think with Marty Makary from the FDA, repudiating this notion. I apologize if that's not correct, but I think it was co-written by the two of them, repudiating the Coalition for Health AI, which I think was, long overdue, because I was watching this whole thing play out in the Biden administration, as you were, and others who were very concerned about that there would be a third-party regulator absent a legislative act of Congress, and that they were holding themselves out somehow as more important than they should be, and that they were going to be empowered by the Biden administration. So glad the Trump administration put an end to it.
Yeah, I think that the clarity that he provided in his conversation with you, I think really drove that point home, that the federal government is not going to be picking winners and losers between big tech and little tech, that little tech has every opportunity to compete on a level playing field.
One other point you touched upon this too was the fact that they are using AI internally now within HHS in closed systems.
Right.
I don't think he told us what systems they're using. He mentioned that they were using two.
He said that they have so far adopted ChatGPT, Claude, and Elsa, but that they were going to be bringing another one online. He didn't specifically mention which one. And I think he may have mentioned that the FDA was using them too, but I don't think it's necessarily the same group. But he said that they're using the HHS staffers are using it for practice, for care coordination, for payment, and that they were going to informally be evaluating the impact of these tools on productivity of the staffers. It's like in any other, we talk about the use of AI by doctors, allowing AI to do things like scribing frees up their time to spend on higher value tasks or eliminating duplicative tasks that you don't need a physician to actually do. And so I think that we're going to see those same kinds of efficiencies, over time within federal agencies, including HHS, which I think will be a really important step forward.
Right. When so much of what the federal government does is duplicative and
Yes.
and historically is just, moving paper from one
Yeah.
person to another or double checking something or approving something. Okay. So was there anything else we want to touch on with the interview with Jim before we move on to the next session?
Well, I think that the alignment between you kind of like the alignment between the kind of forward thinking, I think what really also was important throughout the day. And one of the big benefits and values of a conference like our conference was that we were bringing together some of these parties that may not necessarily interact that frequently. And I think we're going to see a lot of value from that too.
Right. Yeah. Well, that was good. I mean, we can talk a little bit about that, but we'd had a great mixture of policy people, government officials, innovators from in different types of businesses focused on healthcare. So it was a great mix of people. It really worked out well to throw these people together. Let's talk a little bit about the panel that you just mentioned about freeing up administrative burden for physicians. And because this came up in several different panels, but there was one specifically when they talked about, doctor burnout, lessening doctor burnout, increasing physician productivity, and allowing them to focus on their preferred activities, which is making people healthier and not compliance issues.
Yeah, so the first panel of the day was moderated by Tracy Chadwell, who's from Capital 1843 and is in the silver health space. And we also had representatives from Hippocratic AI and Council Health, as well as Jacob Schiff from CMS, and who was very involved in deploying the access model. So there were a couple of really interesting highlights, actually quite a few highlights out of that panel. One of them was that you've got these health tech companies that have the capacity to provide basically a doctor on the phone. You've got information to make the process of the actual delivery of healthcare more seamless for the patient. You've also got the ability to have individuals get a lot of healthcare information and then sync up with a physician if needed, but not necessarily do that. And with AI taking a lot of that load. So what is really interesting is how quickly individuals are going to be able to avail themselves of these technologies that are very low cost. In the case of Council Health, it's actually a free app. You only get charged if you connect with the doctor. And then, of course, they're working with employers and other members to provide these benefits to employees. But what we're really coming down to, and we heard it in multiple panels, is this idea that individuals will eventually have a personal AI. And the goal is that they will have a personal AI that is loyal to them and that can actually help them get the care that they need when they need it, where they need it. And so that's kind of the long-term vision. The other really interesting thing that came out of that panel was Tracy's question. One of the important reasons why healthcare AI is so important is because of American leadership in this space. America needs to be the leader for security and national security reasons, but also for well-being for the citizens here. But one of the things that she was asking about was China. And we've got examples in the pharmaceutical development area where China really is closing the gap with the US, if not already ahead of the US. And so these questions become all the more important. I think that the next summit, it's going to make a lot of sense to focus very closely in on this China question. But we've got China where the U.S. leads in hardware, but China is actually leading the software AI. So we've got a lot to sort out going forward. But I'm really encouraged by the types of apps that we have already launched and deployed, and the ability of and willingness of HHS to really help make those accessible to people and, in a very real way, either through demonstrations or through new approval pathways, for example. So that panel, I think, actually deserves a couple of days worth of time.
Yeah, that was a great subject. I mean, I think it's funny. I mean, my takeaway on the China discussion element of that was that they're focused on this area. Obviously, we've got the biggest technology companies in AI. We're better on the chips and all these things. But because they've been sort of resource constrained, they're using it in different ways and they're using it aggressively. So they're on maybe a different developmental pathway, but it's very threatening. We shouldn't assume just because we have like the top 10 AI companies in the world that they're not a real threat in this area. And I think to your point on the drug discovery, there are portions of that where I think they are subsets of drug discovery and development where they are clearly doing a better job than the United States. Not necessarily overall, of course, but there are areas where we really need to take notice. But I thought that panel for me was really interesting because when they were talking about their companies and how they're going to improve patient care, there's all this dominating talk about, oh, the physician's going to get eliminated. We need to make sure that there's still a human making these decisions. You're going to be deferring to a computer program, or the nefarious payer is going to run it through an AI program and deny you care. That's not the vision they portrayed by any stretch of the imagination. I mean, they portrayed a vision of AI on my side, helping me navigate the healthcare system, and also, to your point, have a personalized AI assistant that I can consult about my issues. So I'll have more access to care, and then I can get to the physician or nurse when I need to and not when I don't need to. And when we're interacting, we're focused on what's really going on. I can send them the report out from the AI or what I'm thinking is going on, any medical records I need them to have, and say, hey, look, my heart's been going a little berserk for a while. I changed my diet. I did this. What do we think is going on here? And they can decide whether or not I need to come in. But it was really a pro-patient vision, and frankly, a pro-doctor vision. It was not this dystopian view of doctors being suddenly unemployed.
Right. And even like two panels later in the day, they spent a lot of time talking about how tech assisted or tech driven care is going to be the standard of care. But there was never discussion that there wouldn't be a need for doctors. And I think to your point about your own personal AI agent that's loyal to you, that is, really covering your healthcare, you wouldn't even need to do the printout. It would automatically be shared with your provider, or it would automatically be elevated. These tools are already elevating the more serious cases to the physicians that are connected. And so I think that when we kind of sit back and look at what is being done, it's absolutely for the patient. And if I can share a personal anecdote that I was able to observe in the last panel of the day, William Pava was talking about how he cut the first check to a heart monitor company. And at the end of the day, our photographer, Josh, came up to him and pulled it out of his pocket and showed him that he actually wears one. That was
awesome.
That's what this conference really highlighted, was how AI is going to improve our condition, the human condition. It's going to provide access to care where and when that patient wants it, needs it. And it doesn't matter what zip code you live in. You don't have to be near Cedars-Sinai. You don't have to be near Mayo. You will have access to care regardless of where you live.
That was a great panel. William Pavia, who you've known far longer than I have, and John Bertrand, both innovators, both running their own show out there, both very successful. John, interestingly, is a veteran of Epic Systems, and then he decided to go out on his own and develop an AI diagnostic tool at Digital Diagnostics that reads your eye and then tells you if you have something that can affect vision loss, a health condition. The first approval from FDA and then reimbursement from CMS. I believe it was the first AI-powered device to get reimbursement from CMS is for diabetic retinopathy. So it scans your eye, then it tells you if you're at risk of blindness from diabetic retinopathy. And William has a different approach and he lives in Oklahoma, so he's a different approach in that he's looking at your medical records to spot susceptibility for diabetic retinopathy and use it as a screening tool and get people under care and get a more serious look. But they were both very focused on rural healthcare. I mean, yes, they talked about the opportunity for urban resource deprived areas, but the number one disparity, and William ran through some of the statistics were horrifying, but the number one health disparity cohort is going to be between urban and rural healthcare, and how access to physicians are so limited in many rural areas, especially specialists. And they both seized on this, that AI has a tremendous opportunity, again, not to fire doctors, not to cut doctors out of the system, but even to empower them and empower, say, a general practitioner, an internal medicine physician working near an Indian reservation in South Dakota or some other rural, resource constrained place, and project that technology to them and allow people to get state-of-the-art diagnostics and information. The physician can be looking at their phone or get on the computer and have the latest medical information, because the pace of new medical learning is so quick, so fast now, that you're going to be making doctors significantly better, quicker with these new tools, and give people really the best specialist care they could ever hope for.
For a lot of these patients, they've never had specialist care, and they're not going to be able to get it. As William was pointing out, if you're an hourly worker and you have to drive 3 hours, are you going to really take off work and lose that income if you're living paycheck to paycheck? I mean, it's just not going to happen. And John was talking about deploying his technology in Bangladesh. So you're really talking about people who are, for the first time, having these encounters that are specialty encounters in medicine, that don't involve an ER.
Right. I love that panel. They were both really interesting. I mean, one thing that John said, which was, I think the only discouraging thing that he said, was if he had to do it over again, he wouldn't have picked an FDA regulated field to do this in, because it was so hard. And he talked about FDA moving the goalposts, changing the standard, and having staff that really does not understand AI and is approaching these technologies from an approach that doesn't really apply to AI, whether it's the cycle or what. And it was really kind of a bummer to hear that, somebody has been as successful as he is, and a real pioneer, and talk about looking back on it, maybe it wasn't worth it. He could have made more money focused on a different area.
That really is why I think you and I focus on healthcare, is because we know that it is possible, what's possible, right?
Right.
But that the obstacles, it's not a lack of technology. It's not a lack of smart minds. It's not a lack of potentially available capital. But what happens is that goes somewhere else whenever you have too many obstacles in the way. And when there's overreach into areas that don't involve reasonable safety. So Tom Keene was talking about cutting 34 of 60 certification program requirements and modifying 7 others. That is a key moment, I think, in policy, in the same way that the quiet introduction of 401ks happened, that really created a revolution. So he talked about this being the case, but he also said that, I think he said in the spring, that they were going to do the same thing with APIs. That's where you're really going to see potential revolution in innovation and healthcare AI, is when the APIs go through a similar revision of these regulations. That's going to be powerful. That's going to be a game changer, I think.
Right. So a big focus on that conversation was on interoperability, sharing data between providers and health record systems, apps, health records. They had a wide variety of views, which was interesting because, Brian Miller is a physician, practices at Hopkins, and he's also a fellow at American Enterprise Institute. Vijay Pandey is wicked smart, PhD, AI pioneer, an investor, veteran of A16Z. Tom Keene is also a Trump 1 veteran, and now he's the director of the Office of National Coordinator and the Assistant Secretary for Technology and Policy. And then Seema Verma, who's the CEO of Oracle Health and former CMS administrator. They had different views about how this is going to play out. Tom was more optimistic, of course, about we're going to get operability, it's going to work, and it's all going to be good. Vijay, interestingly, said it's not going to happen. And it was a very provocative thing to say. He's not a cantankerous, and he's a really nice guy. He wasn't doing it. He just was talking about the motivation
Right.
for people not to share data is pretty high, and there are barriers. Now, when Tom was talking about now that ONC is going to start to regulate the APIs, it's a much different approach. So it's going to be basically how you share data, what flows in, what flows out. And if I fully understand where they're headed, it was really big news that that's what they want to do, instead of talking about the requirements for sharing data and the certification processes for receiving data. Now they're going to be going right into your stack and saying, this is how you're going to have to construct this in such a way to allow data to come in and come out. I would think there's going to be a lot of companies who are nervous about this, and a lot of establishments that are nervous about this type of regulation.
So Tom Keene, who's also a former, he's still a physician.
He's still practicing. Yep.
He said that the new regs are coming out before Christmas. What those look like will be extraordinarily telling for what's coming for API. I'm pretty optimistic because I don't think anyone was really expecting this to happen, and particularly this soon. And his comments on doing this for API didn't make the news, but I think that's the real game changer. They're both game changers, but the API one is the real game changer. And it's interesting. So, everyone on the panel wants interoperability. They want it in different ways. Some I think are okay with centralized, and some are very much advocates for decentralized. And in my personal opinion, is decentralized is how it's going to happen, because of how healthcare data informs treatments and information about the individual. But they all agreed on the problem being the lack of incentives in order to get to interoperability. And Vijay Pandey's point was that the way that you would get there would be a full stack solution in healthcare. So think forward, probably more than a couple of years, probably quite a few years, but you may have your personal AI agent that is a full stack healthcare solution for you. In other words, you're not going to be having, 8 different devices and tracking of you from 8 different companies. It's going to be one system. And so
right. I think VJ hit upon that. That was another provocative thing he said, where he thought the best care is basically going to be the physician, the hospital, and the insurer. It's all self-contained, right? And your AI exists within that ecosystem. Yes, you can reach out for other care, different opinions, all this stuff. But the hospital, for instance, is going to use AI to optimize your care when you're in the hospital, optimize it when you're discharged, or if you're using cash. I think it raises some very interesting questions about the future of reimbursement and what the optimum insurance construct. And Mike Bertolini, big CEO in the insurance industry, has been touching upon this and criticizing, even though he's a Democrat, he's criticizing the way the ACA has been playing out. But that was an interesting point, because we've been so focused on, I developed an app and I can't get access to this health record, but they want to share it with me, and I could tell this person how to take better care of their knees or whatever the heck it is. Or the frustration of individuals going from one hospital to another hospital, and they have to fill out all this paperwork, or they show up to the appointment and your records haven't been sent over. But that very much in that conversation felt like the past, especially the way VJ spoke about his vision for the future.
And remember, he was also talking about direct-to-consumer apps, right? So I tried to touch on this in my panel, but we didn't really take off on this. But this question of, if you have an app that's, let's say, $100 a year that covers a lot of what you want in healthcare, what does your insurance need to look like? And I think that this full stack healthcare AI agent conversation, that is really going to be critical to what the future of insurance looks like. It's going to look quite a bit different if you can deliver 90% of what a patient needs and wants in an average year through an app.
Right. And help me. I'd have more access, wouldn't be discouraged from seeking advice because it's such a pain in the neck to take time off from work and
Right.
do all this stuff. But I can sit there and do a search and say, and start to figure out what's going on. The other thing that Tom Keene touched upon, because he's a radiologist, which was interesting. And I think John Bertrand touched upon it too, with the scans going on with the retinal scans, is the volume of scans using AI that a physician can crank through is dramatically increased. And it doesn't mean necessarily that they are going to make more money, although that is a logical outcome, but they can ignore the ones that are clean and focus on the ones that are questionable. And they can look at a lot more, and they can also focus on questions that the AI raises with a much bigger database of scientific information to inform those readings. Again, this wasn't about doom and gloom for physicians. It was a positive indicator that AI is going to help them be more productive, help them be accurate in their readings, avoid burnout, and focused on the readings that are questionable. They really need to use their medical training and expertise and say, wait a second, here's a reading, here's a scan that I really need to take another look at, or we need to get a second opinion on, and we need to flag it, and we need to get this patient back.
Yeah, absolutely. And I think that it's not that there isn't going to be a rough transition for some in the medical field. There will be some disruption there, of course. But I think that really focusing on these positive stories of access of healthcare for people who have never had enough, never gotten it, and for what it means for other individuals who do want to be healthier. These tools exist today. It's not in the future somewhere. They actually do exist. Is kind of going to take us back to the second panel of the day, which focused on states. And right after our conference, we had the state executive order. But really what the focus on this panel was, Caden Rosenbaum was the moderator, and we had Zach Boyd from Utah's AI office,
right?
Adam Tierer from our Street Institute, and
Mark Sendak from Vega.
Yes, Mark Sendak from Vega Health. So what this really, I think that there was close to unanimous agreement in the room that having 50 different regulatory systems for AI was a non-starter. That is
right.
Absolutely detrimental to AI. And so it was very exciting that this AI EO came out last week. But I think that one of the things that we see from Utah is the ability for states to help cultivate AI health in their states and other AI
right.
technologies, but really to pilot them, pioneer them, and then allow them to expand and possibly get real world evidence and elevate it to the federal level if that's something that they want to do. And then the other really exciting thing was Mark Sendak of Vega Health, who's formerly of Duke Health, and who's also a physician, being able to create a Costco type evaluation process for healthcare AI. A lot of what we talked about centered around having this great technology, but it not being adopted, not being
right.
used, not fitting in a hospital workflow, for example. And so what Vega Health does is they can help validate these products that are pioneered and developed in a single hospital system and put on a shelf, put on a Costco shelf, if you will, in order for other hospitals to take that white labeled technology into their own hospitals, but also provide the evaluation of that tool. So that's another example of how small tech and how technology deployed in middle and small markets across the country is going to happen.
Right. I thought that was Adam Thayer, who's been a long time warrior in the fight to advance AI and against stupid regulations, and has written on this and is a machine. He actually shared a couple personal anecdotes about how AI how he had used it for his own health challenges at various times to positive effect. It was a very interesting panel because Zach disagreed coming from Utah. Now, Utah has a different approach to AI regulation than some of these other states. Illinois has a horrific law on the books, of course, as you would expect. But Zach was skeptical of federal preemption. But they did have a lot of, and I wonder if Zach would have felt that way if, for instance, he was an innovator working in Illinois or working in California. I think, being in Utah, he has a comparative advantage in establishing procedures to allow innovators to flourish in Utah to Utah's benefit, and other states are going to be left behind. This was a huge fight in the big, beautiful bill. There was Ted Cruz had led an effort, Marsha Blackburn as well, to enshrine in federal law this a 10-year moratorium on state-based AI regulation. There was an attack from the right, most notably Mike Davis, who's big in Republican legal circles, and Steve Bannon, to say, look, we don't trust big tech. We don't trust these guys. Take it out. And it did. It dropped out. Then the Trump administration and the president himself, after talking with a number of people in the field, said, no, we got to dominate this field, and we cannot allow, we're going to kill ourselves and really hobble the country if we don't establish a federal standard. This was, incidentally, this is a big tension historically on the right, who are, more sympathetic to federalist concerns, but we had fought this in the Bush administration of federal preemption on drug regulation, drug and device regulation, FDA over states second guessing various technologies that FDA approves. And now it's playing out in AI. Some states are saying they're going to sue over this executive order. But really, I take it on face value, talking with some of the people who provided input on this and wrote the executive order, that this is about allowing this technology to flourish.
Yeah, so our conference was, I think, a day before this EO was issued, and so not knowing what was in the EO and what could have been in the EO, I think one would have a different perspective on it than actually seeing it. And so
that's a great point.
So when Zach Boyd was talking about it, I think that a lot of what the state attorneys general were talking about was suing immediately if it infringed upon state authority over providing safety for their citizens. I don't think that this EO was that. So I think that there's going to be a more muted response from the states. And I think that this is going to be a legally defensible EO compared to what was being discussed previously, what was being, reported and floated around early on. And one of Zach's points, though, which I think is a really important one, is that, the fact that there are 1,000 state bills addressing AI doesn't mean that there are 1,000 bad ones. Some of them are neutral. Yeah. Some of them are within the legitimate scope of state authority, and some of them are horrible. But when we talk about there being 1,000, we're not really focused on the ones that are truly bad. And there's usually a dozen, right? The dirty dozen that we saw in this last session. So I think that was a really important point that I really appreciated him making about this discussion, is that we don't want to say the sky's falling, when in reality, we are very concerned about a handful of states in this area.
Right. And it's funny because I just to go back to where we started, then we got to look ahead. But I asked Jim O'Neill about his views on preemption. And of course, he's in a position, he can't really tell us about the executive order that's about to pop that night or the next day. But he talked about his own experience in California, and they passed a terrible law. And he said, if Newsom vetoes this thing, I'm going to praise him, even though I'm a harsh critic of Governor Newsom in other areas. And sure enough, Newsom did veto it. And it was a great thing that he did, because it was a horrific bill. So with this first one's under our belt, looking ahead, we've got what do you think 2026 is going to hold? Do you have a couple minutes to share about what the big fights are going to be moving ahead in 2026, or policies to watch?
Yeah, we're still going to have a lot of fights at the state level. That's not going away. That will still continue. And then I'll be watching to see if states sue over the state EO. I don't think it's going to be the groundswell that we would have had with the potential EO. So one of the really exciting things that I think I'll be watching is Keene said during the panel that he was briefed on access, and that they're probably going to be allowing tech companies to be Medicare Part B providers. That's a huge game changer. And it does play into this idea that you don't need doctors. However, that's not what this is. I mean, if there's if
it's what it's about is reimbursement.
Right, exactly. And so this is potentially another game changer because you don't have the traditional medical industry that sometimes stands in the way of innovation, right? And new competition as a player. And that is something that I will be watching very closely because I think that's another very big potential transformation point in healthcare in general. And I think that what we're looking at is a generational change in the way healthcare is delivered. And I think it will be to our benefit. And I think that the right people are working on it inside government at the moment.
Yeah, it was an exciting group. Well, Naomi, as usual, I could have spoken to you for another hour. But so thank you. And I look forward to the next opportunity. And Naomi, I want to thank you for coming on and for all the work you put into the conference, because it was a great inaugural conference, and I look forward to the next one.
Absolutely.
I've got to thank our sponsor, Survivors for Solutions, and our producer, John Cece Swartacki.